Can folks out there hear me okay? You can have a thumbs up or mention in the chat. I know you can hear me. Angus, you're right there. People online, if you can hear me, just trying to make sure the microphone's working. Someone could say something in the chat. I'm gonna go with maybe not working. Or is it very quiet? Is that better?
Somebody said they can hear you.
You can hear me. All right.
I can hear you.
All right, good.
In the school, you know.
Okay, good. All right, so let me flip back over to the PowerPoint.
All right, we're gonna get started. Thanks everyone for coming to this here in person. Appreciate having you. It's going to be, I think, for a much more dynamic discussion than when I was kind of like monologuing to a screen last month. So we're continuing the airway theme that we started last month. Just some kind of quick announcements. We have a new webpage. Should be held at ne.org/EMS-classes. And so what you'll get, that's what you see over here on the left. It has, so it's got a list of all the M&Ms with the date, times, and the registration link there. So you can see all of them there. They'll eventually have Trinity's Connecticut course offerings as well. If you also have a Connecticut license, they'll be posting all their stuff there. We have a new Instagram account. It's TH of NEEMS. If you follow us, it's all the same stuff that gets posted on our Facebook as well, which is Trinity Health of NEEMS. So all the M&M stuff we promoted on those two sites, we're going to be sunsetting the Facebook group that we've been using in favor of using the official Trinity EMS social media accounts and outlets. So for those of you online, you don't need to do anything. The polls are going to pop up in the chat for you to take. For everyone in person, go ahead and scan the QR code with your phone. That's going to take you to a web page where, as I get to slides that have poll questions, then the ability to respond will pop up a page that it will take you to on your phone. So we can start with our first one. How do you feel? Yeah, I can't see the results online, so I don't know if they're trolling me or not. Probably. I know you would.
Most people are fair.
Fair.
Fair and best.
Good. So last time we went through kind of a bit of anatomy, physiology, pathology, talked about physical for people that have kind of airway emergencies, and then we talked about BVM and non-invasive ventilation. This time we're going to be moving into more invasive airways, talking about supraglottics, innovation, and what goes wrong with it, and then surgical front and neck access, and then we'll talk through a couple of cases. So starting with the discussion of supraglottics. So these are designed to go in the airway of the glottic opening. So they're going to kind of fit right around here. So there's the glottis, and there's the glottic opening, then coming down to that would be your vocal cords, and then down the trachea. And so they're going to sit up here. In terms of the devices, you got your LMA, combi tube, King, and iGel. It's pretty much all of them that are in existence, or they're very similar to this. So the traditional LMA has an inflatable cuff. Some have a gastric port, some you can innovate through. You should never ever see these in the field. They're basically exclusively used in the OR because they're, I assume, cheaper for them. They're used every day, but they're really not appropriate for pre-hospital use because they don't stand up to the roughness that they need to in order to succeed in the pre-hospital setting. You got your King tube, which has 2 balloons and 1 port. There's a gastric side port that you can pass a suction tube down. And basically those balloons plate above and below the glottic opening, and then you're just kind of squirting air over the laryngeal inlet. The combi tube, does anyone have this anymore?
I think it's
Good.
They were.
Good, because there's 2 ports, 2 balloons, 2 lumens, and if you're doing the math, 2 times 2 times 2 is like 8 ways to screw it up. Because there's only one correct sequence to do everything in. Otherwise, you end up, you bag in and then you get, stomach contents out the other side, or you inflated the wrong balloon. These things are horrible. So never use fun. They're awful. And then the eye gel. The eye gel does not inflate. It is a sort of rubbery type material that goes down and then forms that seal around the glottic opening. It does have a gastric port that you can pass a OG tube or a catheter down. And you can intubate through these if you have the right equipment, which is going to be a flexible endoscope, which I don't think anyone in the field is carrying, but we have it in the ER. So it's like a flexible bronchoscopy scope kind of thing. And we'll put the tube over it and then put the tube through the LMA, get that flexible scope to go down the glottis and then slide the tube down. Got a question?
I know that their literature actually suggests using it
Yeah.
from the manufacturer. We
Yeah.
tried it on mannequins and it sucks.
Yes. Yeah. You can try to do it blind with a bougie. When I have tried that versus having the sterile thing, it's pretty low success rate. The element has to be in exactly the right place for that to work. Yeah. Igel in German means hedgehog. So what is your preferred supraglottic airway? King, combi tube, eye gel? I 100% eye gel online as well. Yeah, good. It's my preferred as well. I think it's probably the best device for the flexibility of things. So, talking a little bit more about the eye gel, since it is the predominant one, I want you to think of an eye gel as an internal BDM. So, the things, what are some of the things that make a patient difficult to bag? Anatomy? Tell me more.
Just the different shapes of things, like say somebody has even like a mustache or a beard.
Okay, facial hair,
Or they're missing teeth,
missing teeth,
big tongue.
big tongue. Okay, anything else that'll make a patient difficult to bag? How about, yeah,
An obstruction.
an obstruction? Okay. How about like physiologic reasons? Someone's gonna be hard to bag. Yeah,
Obesity or causing
Okay.
like
good,
larger like neck anatomy.
good. Obesity or extra like tissue in the neck.
Facial hair.
What do we got?
Facial hair.
Facial hair, yeah. So we're talking physiologic reasons, stuff inside,
Facial
anything in the trap, facial trauma. How about bronchospasm? Okay, they're hard to bag. Whether that bronchospasm is from anaphylaxis or from asthma COPD exacerbation, they require high airway pressures, the same way that a COPD patient does. So while the LMA bypasses a lot of the external anatomic issues, their facial hair doesn't matter. As long as you're able to get it in, the trauma to the face doesn't necessarily matter. Where the LMA falls apart is still people that require high airway pressures, whether that's because of obesity or bronchospasm or some other physiologic or pathologic reason. So, how do you size your eye gel? Okay, so there's ideal body weight. Some people use actual body weight. You can also do it based off of length, right? Because that's what a proselyte is going to tell you. But that's just a one step removed from the ideal body weight. It's just kind of figuring that out for you. So like I said, the pitfalls. The number one pitfall actually is not putting enough lube. And this is directly from the manufacturer, that you're supposed to put that cup, when you pull it out of the package, it's in that little plastic like arm there. That cup that it's sitting in is designed for you to squirt a bunch of the surgical lube gel on there and then to just get the entire end of the LMA wet. That's actually their number one thing. If you actually read the manual, is you need to use enough lube, because that's actually what helps it make the seal, what helps it seal. For positioning, you can play with that by either, by working on either pulling the element in or out, or sometimes twisting left to right a little bit to see if you can get a slightly better position. You'll be able to feel that, whether you're actually bagging or if it's just, coming out of the mouth. And like I mentioned before, the need for high airway pressures are really where this kind of starts to fall. So an oversimplification in at least one study, they found that they were looking at all of the different ways that you could size an LMA, and what the pressures were. The pressure where the LMA seal got broken, basically, was what they were studying in surgical patients. And the best method was to, in women, just do a 4, and in men, just do a 5. That's how they got the best seal. So that's what I've adopted. And honestly, it seems to work pretty well. And it also reduces my cognitive burden if I'm running resuscitation and I don't have necessarily like enough people to kind of be able to stand back and think about what their ideal body weight is. Because if you think about the weight ranges on those, they're pretty big ranges, to be honest. And you have to have a very small patient to really need a 3. So women get a 4, men get a 5. It's a oversimplification, but it's a totally valid way to do it. And is the case of everything with pediatrics, it's whatever the prostate tape says. So how do you size your iGel? There we go. Online, Renee.
There are, you and 73% said ideal weight.
Okay. Yeah, and that's good. All this airway stuff is supposed to be based off of ideal body weight, because if you get fat, your lungs will get bigger. Right? I've not been putting on lung mass since graduating med school. So it's not, I don't need, 3 meters of tidal wall. Right? My lungs are not going to be bigger. Good. So, like I mentioned, that plastic bit is designed for you to squirt all of the lube in there so that you then reinsert that on there to get it all around the edge without getting the lube all over your hands so that you can't hold anything. Designed to just be inserted straight in the mouth. Something that they note in the user manual, you'll sometimes feel a give way before the endpoint resistance is met. This is getting the bowl of the iGel through the pillars that are on either side just above the glottic opening. So you may feel resistance, then it'll kind of give, and that's when you're in place. Once the resistance is met and the teeth are at the bite block, it does require some steady inward force. And hopefully the ones that you guys are using have the strap included. Okay. Bay State, they bought the ones without the strap because they're probably like 50 cents cheaper, and so they show up with the same things. And technically they say no more than 3 attempts in one patient. I would say like probably 3 attempts. If you're having to reattempt the element multiple times, you should be changing something, whether it's the airway positioning or the size of the element itself or reapplying the lube, something, right? Because just doing the same thing over and over again, just like an intubation, is going to trick. So special considerations for these. For pediatric patients, you're going to use Broslet tape for sizing. You talk about different ways of sizing. You want to gather all of your equipment before insertion. So that is going to make sure that you have the strap. It should all come in the kit, right? It comes with the strap and the lube and everything in the kit with the LMA. So that should be all ready to make sure you got your bag, peak valve, whatever else you're going to use is ready to go. Like we said, emphasis on lube. This is a case where you're going to want to remove the dentures if they're in there, because it's going to give you more space to work with to try to get the LMA in. And pre-oxygenate the patient to the best of your ability. And as always, that's suction. So, what would you do if you noticed aspiration when you had an LMA in? Good start. Good start. Anyone else? Other thoughts, suggestions? How about this? Do you consider an I-gel to be a definitive airway? Whatever that means.
Said no, 10% said yes, and someone commented, hospital's gonna pull it anyways and immediately intubate.
Okay, so that's an interesting point, and I do want to comment on that. Now, the reason that the hospital, especially if you go to Bay State, is going to immediately pull the I-gel and change it out for a tube is not because it's a bad airway or an ineffective airway. It's because it's a teaching hospital and they have literally more doctors than they know what to do with on a given resuscitation. So there's one person who it's their sole responsibility to manage the airway, and they have all of the toys to be able to do that. So if you go to Bay State, yeah, there's someone like that's their job and they're trying to get experience. So they're going to pull it and replace it, even if it's working just fine. Yes.
Specifically at Big State.
Yep.
Patients were brought in and intubated, because I've heard of or seen patients get extubated by the hospital staff and MSS team after pre-hospital brings them in. Even when there was like confirmation, the airway was in place. Is that also kind of a student teaching
So,
aspect?
so for people online, the question is is it also like, because they're a teaching hospital, that they may pull a tube that's confirmed is in place and then reintubate the patient? That generally shouldn't be happening. If the tube is getting pulled, it's presumably because it's displaced, which can happen. Like it can happen just in moving the patient over, right? So I don't think in the 5 years that I was there, I never saw a patient that we willingly removed a good working tube. I mean, they when they verify or they confirm placement, they like to do it with laryngoscopy so that the residents get more practice doing laryngoscopy, but that's not in an effort to remove the tube or reintubate the patient. That generally shouldn't be happening. But to go off what I was saying before about, they have more doctors there than they know what to do with in every resuscitation. If you roll up to one of the community hospitals, like Noble, or, if you come to Mercy for that matter, I'm probably, as long as the LMA is working, I'm not going to pull it immediately, right? Because I don't have that access resources around like they do in Springfield. So if it's working fine, I'm just going to leave it for at least a while. Will I eventually want to change it out? Probably. But if it's working fine, I'll just leave it for at least a while. Which gets us, to this idea of what is a definitive airway? Who knows? It's not really well defined. I think there is some concern with how long you can leave an I-gel in versus an endotracheal tube, because the amount of pressure that it's exerting and potentially causing tissue necrosis or something. And we're talking here leaving it in for days, the same way you would an endotracheal tube. So that's probably the main reason that an endotracheal tube is considered definitive. Plus, when you have an inflated balloon in the trachea, your risk of aspiration goes down. Although in all the studies that I've looked at, looking at I-gels specifically, the risk of aspiration is on par with an ET tube. It's really just the fact of mucking around in the back of someone's throat is what increases their risk of aspiration, more so than necessarily the specific piece of plastic that you're manipulating in the back of the throat. So if we are going to suction, you can either go down the lumen where you're bagging to pass it directly if you're going to try and get down into the oropharynx and bag, or if you want to decrease the stomach, if you want to decompress the stomach, then you can take a size 12 French gastric tube, and when you put it down this port off to the side there, if you've ever even noticed that little port that's there, it comes out at the distal end of the cuff or the bowl. So that will pass straight down into the stomach. So you can put a tube down there and you can evacuate stomach contents. And it does vary by size of the LMA, but pretty much everyone is 12. And certainly you can, the 5 can take a 14, that doesn't mean a 12 won't work. So if you keep just 12 in your mind, then for all but the smallest patients, you can pass that 12 down there and you can use it to decompress the stomach. Now, what is this guy for? Passive oxygenation, very good. I've seen people think this was the suction port. It is not. So if you attach O2 to that, it's gonna take it into the channel where you're ventilating, and it's gonna continuously kind of blow the O2 on there if you were wanting to do that for sleeps. It's not suction, so do not attempt suction through that. Otherwise, you kind of may have a hard time bagging.
I feel like the only reason for that is for when you're trying to intubate through it, is there's some passive oxygenation while you're shoving something else in.
Yeah, but I'm also not clear, I'm not certain exactly where it goes into the lumen, because you'll probably be obstructing where that is when you're putting the tube through there. The scope itself, if you're intubating through it, has a port for oxygenation while you're doing it. So I'm not sure why that feature is there, but just know that it's not the suction. All right, so let's talk about intubation and some of the things that can go wrong. So cardiac arrest, what's your go-to airway, supraglottic or intubate? Okay, so a little more. So there's not a, we'll talk about intubation, we'll talk about the NAEMSP policy on this a little bit later, but there's 3 things that I want to emphasize in terms of intubation. Ear external notch, which is your positioning, progressive laryngoscopy, which is how not to get lost when you're getting ready to put in the tube, and then the different errors that can happen with the laryngoscopy. So this is your patient laying down in the supine position. This is ear external notch, which is to say that opening on the ear, like the ear hole, external auditory canal, should be even with the sternal notch, which is right above the manubrium right here. So I always tell, patients or people, when you ask someone to smell the marker, right? They don't do this, right? They don't hyperextend the neck like we do with our airways, right? What do? Lean forward like this, right? And what does that do? That brings your ear, the plane of the face, the ear, external auditory canal, even with the sternal notch. So it's the natural, actual sniffing position, right? No one smells like this. They're like, oh, what beautiful flowers, right? Like that's not a thing. So progressive laryngoscopy has a mnemonic EVLI, which means you're looking for the epiglottis, the vallecula, the larynx, and then you intubate. So you start midline to identify the epiglottis, you engage the vallecula, you lift, then you visualize the laryngeal inlet, and then you intubate. The process and the skill of exposing the glottic opening is a separate skill from tube delivery. Because there are plenty of times, I'm sure, where you've had a great view and you just can't pass the damn tube for whatever reason. Because those are separate skills. And it's even more important if you start using video laryngoscopy, because it really is completely different. So these are some videos. They're going to illustrate some different errors that can occur during intubation. We'll watch it. And then I want you to tell me what you think was making it difficult for them to get the view. Too deep, okay. Anything else? I don't think they were actually too deep.
I mean, they all got nowhere near the black.
Okay. How so?
I don't think we ever saw the other ones.
Yeah, so they were completely off midline. Okay. So it wasn't that they were too deep, it's that they were completely off midline. So it's what if you were midline and you went too deep, that's what you would see. But their problem was that they were completely off midline. Okay, here's the next one. You can see he's pulling so hard that the tip of the blade is shaking. Like, oh, suction, that'll, oh, no. Okay. Okay. Can someone say back up? Okay, so what are we thinking? Hey! Hey!
Split it?
No, this guy is way too deep. So you can see the arytenoids there, so he's finally found the glottic opening, but he's currently using the Macleg Miller and lifting the epiglottis, which is gonna make tube delivery difficult. Because now, you got the curve of the Mac blade pulling up on it, so it's gonna quote unquote be very anterior. And that's because you're pulling it anteriorly. So this guy was mostly too deep the entire time, and he keeps overrunning the epiglottis here. And it's actually engaging the ligament there.
I know with video scopes, it's a lot of the time, most people would suggest, especially the high blades.
Yeah.
You know, your main view should not be of the cords, it should be of the epiglottis.
So,
Like the cords at the bottom.
so, yeah, so with a video scope, generally we recommend, because the problem with the video scope is that you can get a perfect picture of the glottic opening, but that is incredibly hard to pass the tube through, which is why I make the point of differentiating between exposing and visualizing the glottis and delivering the tube. So the reason, what we tell people when we're training them with video scopes is that you want the glottic opening to be taking up about 50% of the screen. Because if you have that perfect, I call it the marketing view, right? Just like that perfect opening of the glottis of the cords, and you're like, oh yeah, there's the airway. You can't actually see where the tube is as you're approaching, so you're almost never going to be able to get it in. You got to back up so that it's taking up like less than 50% of the screen, so you can see where the tube is in relation to the glottic inlet, so you can actually get it in there. But in general, this guy was too deep, and it kept running over the epiglottis there. And so eventually, when he was toward the end, when he was using the Macleg and Miller, that's going to pull it more anteriorly because of the shape of the Mac, and going to make it quote unquote an anterior airway and make it very difficult to pass the tube. Anybody's probably not looking at the video view right now.
Are these from ambulance services, or did you find these online?
No, these are all ED patients. That's an OG tube. It's already passed. So you at least know where the esophagus is. In general, like, what do you think this guy's problem is?
The screen is completely obfuscated.
Why? Why is the screen completely obfuscated?
Something got onto the lens.
Yeah, because something got onto the lens because he didn't
Oh, yeah.
He didn't suction, right? So this guy needed to suction the airway more. I tell people you should lead with suction. It's more important with a video scope, but it's a good habit to be into that you're leading, you're suctioning ahead of where you're inserting the blade. So that number one, if you're using a video, it keeps the camera clean, but number two, it's going to help you better visualize all the structures as you're advancing. So lead with suction. Now, if you have a very heavily decontaminated airway, you can use this technique, which is called SALAD, which is an acronym for Suction Assisted Laryngoscopic Airway Decontamination. And you can innovate some very messy airways using this technique. That's just one A brand of suction catheter. It's designed for emergency airway use. So after suctioning, use hardening the suction catheter on the left side of the mouth down to the esophagus to continue draining the contents that's coming up. That very fancy sterile bougie that you can use well using a normal bougie. I have a bougie first time every time coming in, okay? And then we're passing it to. So the main difference between salad and just hitting with suction is that park maneuver on the right end of the airway. So you're suctioning, and then you're realizing as soon as I pull this suction catheter out, it's going to fill up again, and I'm not going to be able to get my view. That's when you take it out, and then you push it down on the left side so it's out of your way, but you're pushing it down so it's still going to continue to suction stomach contents that's coming up, and then you can go for the tube. Now, the decanto catheter, so number one, the suction catheters that we're normally using, those were invented by an ENT surgeon for dabbing on little bits of spit and blood during tonsillectomies. Okay, they're not designed to suck a chili dog through that the patient ate 30 seconds before arresting, right? They're not designed for that. The decanto catheter, that sucker will suck an entire jello mold through it. Like this is made for that. The decanto catheter is also designed so that you can actually disconnect it from, you can put it into the glottic opening, disconnect from suction and pass a bougie down it. So if you really like, if I'm only going to get, if there's so much coming out that I can only get that, see that glottic opening for just a second, I can put the suction catheter in the glottis, remove the suction, pass a bougie, pull off the catheter, put down the tube. Is another method of using the decanto catheter. You can't do that with the standard chromium suction catheters that we're using, even at the hospital. Okay. Tell me what's going on with this. Midline, we're not too deep. Doesn't look like we need a ton of suction. Maybe.
Is it axis alignment?
You said axis alignment?
Or
there might be a piece of that, but the main issue is he's not advancing enough to engage that ligament to lift the epiglottis, and they aren't lifting hard enough. So, what's your go-to blade? Mac 3, Mac 4, or why Mac when Miller do trick?
Answer the question, Bubba.
All right, and we're pretty much everyone's going for Mac 4, okay? How about online, Renee?
Online, we got 63% Mac 4, 33% Mac 3,
Okay.
4% Y Mac when Miller will do the trick.
Okay. So a little more diversity online. Um, so this is a Mac 3 and a Mac 4 blade side by side. The main thing to notice is that, as I'm sure you are aware, and that's probably why you chose it, but the Mac 4 is much longer than the Mac 3. Now, what that means is that this distance is longer. And so if you think about the blade here and this as a lever, the patient's soft tissues in the neck have more leverage against your lifting. So your lifting force, pound for pound, is less effective with a Mac 4 because of the physics of having a longer implement. Does that make sense? So I think I had one patient that I could not intubate with a Mac 3. People make the argument, well, I'd rather have the extra blade in case I need it. But the downside is that, number one, it is a larger blade, so it's taking up more of the mouth space. And number two, the physics are working against you. So if you're using that longer blade, your lifting force is inherently less effective versus the smaller blade. Even if you have to put it, and I've had to sink it all the way in the mouth, and that's fine, but I know that I'm getting much more effective lifting force. And I've had residents that are having problems with the exposure. They're trying to use a 4. I switch them over to a 3, and it's usually people that they may lack the upper body strength to properly get that lifting technique in there. But switching to a 3 almost always helps in those regards. So just something to think about in terms of your blade selection when you're doing your next two. All right. How about this one? What's this guy's deal?
He's having trouble exposing.
He's having trouble exposing the glottic opening. Why? Not putting enough pressure on the molecular. You're right. So he's not. You see, the tip of the blade is off to the side here. This is the hypoploic ligament, and the blade was off to the side in that little space that's created between the ligament and the side of the larynx there. It wasn't actually engaged against the ligament. So that ligament, that ligament is attached to the hyoid bone and the epiglottis. It goes between them. And so when you push on that, it pops up the epiglottis to reveal the laryngeal inlet. And so that's why it's super important not only to stay midline to be able to find your structures, but to stay midline so that you can hit that ligament. Because engaging that ligament is the key to getting good glottic exposure. And that guy was just off to the side in a little pocket there. All right. Receptioning. Hang on.
It didn't leave suction.
Okay, he needs more better suction. But what keeps happening every time you see the epiglottis? The what?
More vomit comes in.
Well, there's that. But the main thing is every time you see the epiglottis, he runs right over it, right? So instead of carefully staying midline and trying to engage that ligament and lift, he's running right over it. And so you would see where, so he's past it, he's in front of it. There we go. We're finally like kind of in the right space. Hey, see what happens the second that you start to actually engage the ligament there midline? So that was, and this can be the frustrating thing is it can be a matter of millimeters, right? And I think a bougie is absolutely the right call for that kind of like a this kind of angry looking airway. But yeah, that was the main thing was he was just like railroading straight over. Yeah, well, you know, who doesn't like a challenge? I got steps out of work. Forgot to take the balloon down after I checked it. So that was too much force or over insertion of the vallecula. So again, just kind of running over the epiglottis and making your life much harder than it needs to be. All right, only a few more here. Again, this is like the quote unquote marketing view. So it's going to be difficult to see your device as it approaches. Now they've picked up the larynx, or they picked up the epiglottis with the MAC blade and they've lifted it. So now it's anterior. And so what you're seeing just on the other side of the vocal cords there is anterior trachea, which is why they're having a really hard time passing that bougie. And what will actually end up helping them succeed is they're gonna over rotate the bougie, so the coude tip is aimed posteriorly instead of anteriorly. But you can like see tracheal rings like just past it, right? Because you're staring at the front of the airway. It's got to make like it's basically got to go like straight down as soon as it passes through the cords. Also, I'm sure all of these feel like they're taking an agonizingly long amount of time, but I'm sure if you were the one doing this intubation, it would seem like it was like 6 seconds, right? I always, when I record these when I'm working with residents, and then after the tube, I go back and replay it immediately. They're like, I had no idea I was in the mouth that long. Okay. So, tell me what goes wrong with this one. So that sure looks like laryngeal inlet. So again, we picked up the epiglottis, and we're making this probably harder than it needs to be. But we've got the bougie through. Yeah, that's good. Then watch what happens when we're trying to pass our tube. Okay, so it's getting stuck. There we go, and then it finally passes. So this is not an uncommon thing with the bougie. So what happens here is you've got the bevel of the bougie is coming, or excuse me, the bevel of the tube is hanging off the bottom of the bougie. And then as you're approaching the arytenoids, the bottom of the tube is getting stuck against the arytenoids because it's hanging off the bottom of the bougie a little bit. And so all you have to do is rotate the tube. And, you know, you rotate it to the right, to the left, doesn't really matter. I rotate it 90 degrees, try again, 90 degrees, try again, 90 degrees. Eventually I get there, right? So that's the thing is when you're getting hung up on the arytenoids right there, just remember to pull that tube back a little bit, twist it, and try again. And eventually you'll get there. But that's not an uncommon issue with trying to pass the tube when you're using a bougie. And I believe this is our last one. Okay, so we got our view. I'm assuming that's CPR ongoing. Okay, what, did you identify a mistake there? Did you see the tube pass before you pulled the blade out? No. So you want to leave the blade in the mouth and you want to maintain your view while you pass the tube over the bougie. Because if you pull the blade out, now all those tissues are collapsing onto it. Will it get there? Yeah, you push hard enough, it'll go in. Like it's going to railroad over it. That's part of the miracle of working with the bougie, right? But you just made your job a lot harder. So maintain your view while you're putting the tube over it and then remove the bougie. Okay. So, endotracheal intubation recap. Ear to sternal notch, that actual sniffing position. Progressive laryngoscopy. So find the epiglottis, find the vallecula, elevate, find the larynx, and then intubate. Lead with suction, and consider MAC3 as your first line. All right, we'll round this out by talking about surgical front and neck, and then we'll take a quick break because those of us who decided to attend in person are going to get to have pizza. So I want to recommend that you use the scalpel finger bougie technique. I'm going to talk about the laryngeal handshake and emphasize that this is a tactile procedure. You're going to see that coming up over and over again when we talk about this, and that it needs to be confirmed with end title. So, have you ever done a crank? Yes, on a patient. Yes, only in a cadaver lab, or no, but I did stay at a Holiday Inn last night. Well, slightly biased sample because of the cases tonight, but, all right, what's it look like online, Renee?
79% have not, 5% have, and 16% stayed at the Holiday Inn.
Okay. That's more than I would have thought. So your structures for this. So the larynx is made up of two different pieces of cartilage. So you've got the thyroid cartilage, which is in front here, and then the cricoid cartilage, which comes up the back here. And then the cricothyroid membrane is what connects to its kind of opening here. Now, the main reason that we do this procedure at this location is, well, there's a couple reasons. Number one, the narrowest point of the airway in an adult is the vocal cords. So this is below that, meaning that if there is an obstruction, in theory, it's above this level. So we're going what should be below the level of an obstruction if there is an obstruction. Secondly, when we come at the cricothyroid membrane here, you've got this big slab of cartilage from the thyroid cartilage. Remember, coming back to here, these two parts, you've got the thyroid cartilage, and then, sorry, I misspoke, cricoid cartilage has this big piece that comes up to the back here. So when you're looking straight in that opening, you're coming right against this nice big flat piece of cartilage there that's going to protect you from damaging the esophagus or any blood vessels that may be behind it. So this is also the safest level to do it at. Some other anatomy to kind of consider, a normal variant. So you've got, this is the thyroid gland that's overlying there. and this is where the cricothyroid membrane would be. It's a normal anatomic variant for people to have a piece of the thyroid that crosses over that. I want to say it's something like 10 to 20% of folks will have that. And the thyroid is a very vascularized structure. So if the patient has that, they immediately like stink. It doesn't mean you've done anything. Another thing to think about, as with when you're darting the chest, okay, do you go over the top of the rib or down under the bottom of the rib? Over the top of the rib. Why? Yeah, so you've got veins, arteries, and nerves on the bottom of it. So similarly here, the top of the opening, there's some arteries and veins that run across there at the bottom of the thyroid cartilage, but that doesn't happen at the top of the cricoid cartilage. So when you're making that cut, you want to err towards the bottom of that opening. Now, I'll go back to this. So I want to talk about what's called the laryngeal handshake. So that's taking your entire non-dominant hand and basically coming over. So for most of you being right-handed, so you're going to take it in your left hand and you're going to come over the patient's face and you're going to grab the entire larynx with your hand and feel around and get a good feel for where all of the structures are. Basically, by palming it with your entire hand to feel. I want you to feel where the thyroid cartilages are, where the cricoid cartilage, the cricothyroid membrane. And that's also, when you do that, you're going to get a good feel for where the structures are, and it's going to help you grab good control of it. Another thing to keep in mind with this procedure, your hands will probably be shaking. So you want to take your palm and rest it on the patient's sternum. Okay, so now the vibrations are only in here from your mild alcohol withdrawal rather than your entire upper extremity, okay, by resting on the patient's sternum. Right, I can't tell if I'm over caffeinated or under alcohol. Okay, so laryngeal handshake, hand on the sternum. Once you make your initial cut, from then on, this is a tactile procedure. You cannot rely on visual landmarks. Okay, so that's why we recommend the scalpel finger bougie technique, because you're going to cut in there. So now you've got your cut. Okay, you're pulling the blade out, put your finger in, and now you can feel, okay, I am definitely in the airway. And then as you're passing the bougie, okay, I know the bougie is definitely passing my finger into the airway. And then when you pull your finger out, then you can put the tube over it and you know that the bougie is in the right place. So the scalpel finger bougie technique supports the fact this is predominantly a tactile procedure. All right, so before we go into the cases, we're just going to take a quick 5-minute break.